Hello guys, this is Dr. Acebedo again. I'm one of the physicians here at Cancer Center for Healing. Today we're going to be talking about thyroid cancer. We're going to go over with types of thyroid cancer, what are we supposed to do, if there is there any recommendations from or any consensus recommendations for thyroid cancer for screening, and then we're going to talk about treatment and what are we supposed to do. And we're going to talk about risk factors, and we'll go from there. Thyroid is a gland here, just right below our voice box, if you will, and you can feel it here, right here where my voice box is. Adam's apple, we call it. And thyroid is involved in our metabolism, and as we know, and it produces thyroid hormones, and calcitonin also is another one that being produced by your thyroid hormone from the C cells that is found in your thyroid. Basically, as most of you, and it's pretty common here that as we age, I've seen a lot of Hashimoto's, which is an autoimmune disease, but that will be a different topic. Today we'll concentrate more on thyroid cancer. So what are the different types of thyroid cancer? There are several types. One is papillary thyroid cancer, and I'll talk first about papillary thyroid cancer. This is the most common type of cancer, which is comprising 80% of thyroid cancer, and it's very slow growing. Prognosis is good. In fact, the survival rate for 20 years survival rate is about 95%. And because it's slow growing, it's rarely detected, and if ever it's detected, people can feel like there's a nodule there. And there are several ways that we can identify if it is a tumor or malignant or benign. So usually we do an ultrasound if you feel something there, and some thyroid tests that we do. Typically in papillary thyroid cancer, thyroid hormones are usually normal, and even there's not much tumor markers that we can use. Most of them are normal. And what we typically do in general, thyroid cancer is usually as far as treatment is concerned, usually it's general surgery, either lobectomy, which is just part of the thyroid gland, or total thyroidectomy, which is removing the whole thyroid gland. And in that case, once it's removed, then definitely going to be on lifelong thyroid hormone replacement. So, but what are the risk factors for papillary thyroid cancer? Usually it's common in women, compared to men, which is 3 out of 1, and most common cause is usually genetic, but there are cases where they have been exposed to radiation, X-rays, for example, or radiation, radioactive fallout when you're close to an area where there's radiation leak from nuclear plant or something like that. And in fact, it's interesting when they had Chernobyl nuclear reaction, people usually take a lot of iodine, and what it does is the iodine it competitively inhibits the radioactive iodine that comes from the environment, and you take high dose, and I believe, if I'm not mistaken, is you take about 140 milligrams of potassium iodide if there's an emergency, and then in case you're close to an area where there's a nuclear reactor leak, for example. So those are the common factors that could predispose you to develop papillary thyroid cancer. And I remember when in Las Vegas they used to test atomic bombs, and I've heard from people they call it downwinders in the southern part of Utah. A lot of them developed cancer, and the most common was thyroid cancer. That was papillary thyroid cancer. So anyway, so the treatment, we're going to talk about the treatment. How do we treat papillary thyroid cancer? The most common is surgery. If it is very small, we do lobectomy, partial lobectomy. If it is bigger, we have to do total thyroidectomy. Now, usually papillary thyroid cancer will metastasize to the lymph nodes, and in advanced cases, it will metastasize to the bone, to liver, to lung, and brain. But this is in severe cases. So after that, usually we do radioactive iodine. If there are remaining thyroid cancer somewhere else in the body, not amenable to surgery, and in some cases we have to do chemotherapy. But this is the different treatments that people can do. Now, in our case, as integrative doctor and in integrative oncology, what we do is basically all goes back to the root cause. Okay, we're gonna need to remove any toxicity and viral infection, which is common in my patients. They have Epstein-Barr is the most common, and then nutrition really important. So almost all cancer cells, they use glucose. And again, really important to use nutrition, and also use repurposed drugs to block the different pathways. So glucose, glutamine pathways, fatty acid, and the different genetic overexpression in the cancer cells. Because even though even though a group of people will have papillary thyroid cancer, but the genetic expression is different. Diagnostic of choice that we do here is the Greek test that we send your blood. It's a liquid biopsy. We send your blood to Greece. They analyze your tumor. It doesn't matter if it is papillary, follicular, medullary, anaplastic, and that extensive report, it's a 24-page report. It will tell me the genes that are overexpressed. The most important also is to identify what treatments would work for this type of cancer you have. So right now we've been using immunotherapy, but that test will tell me if it is PD-L1 positive or PD-L1 negative. In that case, if it is positive, then we can use the PD-L1 blockers, which are the Keytruda, the Yervoy. So we can use those type, but again, it's not all patients will have that expression. So not all will be a candidate for immunotherapy, and that's far as I'm concerned. And when it comes to integrative, because we always based it on the Greek test, because that's what the main test that we do here in our clinic. We follow the Greek test because it's more comprehensive, it's more personalized approach. So number two I'm going to talk about is follicular thyroid carcinoma. This is the second most common, and it comprises approximately 10% of thyroid cancer, and it comes from the thyroid cells and follicular cells. Again, there's no consensus actually in general as far as thyroid cancer is concerned. There's no consensus as far as screening. In fact, U.S. Preventive Task Force has a D recommendation. That means that for asymptomatic people, there's no recommendation for screening. So going back to follicular cancer. So what are the most common? Again, is genetic. What are the most common cause of follicular cancer? Mainly genetic, and we still don't know what predisposes a person to follicular cancer. And it's rarely from radiation. As I mentioned, radiation usually for papillary thyroid cancer. There might be a blood test that we can do in which some of these patients will have some abnormalities in their thyroid, but if we suspect there is cancer, then the next step will be either to do an ultrasound or radioactive iodine uptake. We are trying to find out if there's a cold or hot spot, right? And the cold spot will be suspicious for cancer. So with follicular cancer, the treatment will be the same, either lobectomy or partial lobectomy, or total thyroidectomy. And the most common metastases of follicular cancer metastasize mainly, more than papillary thyroid cancer, metastasizes in lymph nodes. So usually the surgery will be involving the whole thyroid lobe, and also the lymph nodes. And again, typical organs that are affected will be bones, lung, liver, and brain for follicular thyroid cancer. It's a little bit more aggressive than papillary thyroid cancer, but still has a good prognosis compared to other thyroid cancer that we're going to talk about. Oh, there's a variant to follicular cancer, which is Hürthle cell follicular carcinoma, which is just basically a pathologic diagnosis based on what it looks like on the slide. So, but the treatment will be the same. Number three that we're going to talk about is medullary thyroid cancer. Now, medullary thyroid cancer is usually related to family history of cancer, and it's commonly seen in men syndrome or multiple endocrine neoplasia type 2A. They usually develop medullary thyroid cancer. Now, where does it come from? It comes from the C cells with thyroid gland, and this one, there is a blood test that we can check. If you find out to have medullary thyroid cancer, we can do calcitonin, a blood test which will show up on the blood test as elevated. And most common symptom of patient who has medullary thyroid cancer will be some will present with diarrhea and flushing, which is similar to carcinoid syndrome because it's kind of like hormonal issues. And also, as the cancer expands, it can cause some compression in their throat. People will tend to develop hoarseness in their voice, and they might have trouble swallowing. They might have trouble breathing as the tumor expands. And those are the symptoms, but this is more on the advanced stage. So the treatment for medullary thyroid cancer doesn't respond to, again, surgery, as with any thyroid cancer, but doesn't respond well to chemotherapy. So we have targeted therapies for medullary thyroid cancer, which is what we call tyrosine kinase inhibitors, and one of them will be cabozantinib, and the other one was there was sofatinib, and then there's varizatinib. So those are the drugs that typically in conventional setting they use is tyrosine kinase inhibitors. It targets what we call the VEGF, which is a marker for angiogenesis or blood formation. And then there's a genetic component to the medullary thyroid cancer, which is the RET, R-E-T, and the c-MET, which is blocked by cabozantinib. So those are the conventional treatments. And then we now go to the last one, which is anaplastic. Well, actually, there's one more. Anaplastic thyroid carcinoma is the most rare, but the most aggressive of the thyroid cancer. And it can grow in weeks and days, and you can see it really growing fast. Usually, this is seen in older people, above 60 years old. And again, the most common symptom will be compression. This one you can feel right away because it locally invades the tissues. So shortness of breath will be hoarseness of voice, lymph nodes, lymphadenopathies, and usually this one has a bad prognosis once you're diagnosed, even though there are people who are still alive, but really rarely survives. Really bad prognosis. And the treatment for this is, again, surgery, radioactive iodine, or chemotherapy. So it needs to be diagnosed right away. And if you start to suspect that there's something growing there and it's fast, see a doctor right away. You want to make sure this is not the anaplastic thyroid cancer. This happens about 1% of the thyroid cancer. So I mean, it's really rare, but it's very aggressive. Now, the medullary thyroid cancer that I mentioned before, that's about 3 to 4% of the thyroid cancer. And the last one that I'm going to talk about is thyroid lymphoma. And usually that's the most common risk factor for this is Hashimoto's thyroiditis. If you have long-term history of Hashimoto's thyroiditis, you are at increased risk of developing thyroid lymphoma. But again, this happens when you get to about 60 or 75 years old. And the treatment will be pretty much the same as lymphoma, which is the CHOPS and conventional treatment and surgery. Also invades lymphatic system, and the most common symptom will be the same because it's here. So you might have difficulty breathing, difficulty swallowing, you have pressure in your neck area, and then and eventually, it could affect your voice, harsh, because it could affect the nerves supplying your voice box. So those are the most common symptoms that you're gonna have. And again, with lymphoma, you're gonna have to have treatment. And what do we do as far as integrative therapies? So pretty much in all of these cancer patients, all types of thyroid cancer, and what we do in our clinic is knowing the root cause. We do the Greek test. It's the most important to find out the genetic marker, to find out how many circulating tumor cells you have. And then that's pretty much how we work up. And you have the option of doing surgery. It depends on the stage. So there are also different stages, the stage 1, stage 2, stage 3, stage 4, depending on the size and the lymph nodes that are affected. And the stage 4 pretty much when it's spread to the bones, the liver, and lung, and the brain. So that's all for today. And if you have any questions, let me know. And thank you so much for listening to me.